Well, it is quite apropos that I would follow Dr. Wilson, and actually, we only chatted about this yesterday, so we didn't know when we put this together that, I was going to talk. Oh, sorry.
I'll get it for you. Okay. You talk.
I was going to chat about the issue about why. Why doesn't this work and why isn't this in place? And so I wanted to kind of talk more today about the issues related to community supervision and substance abuse treatment and focus my discussion. There are a series of articles. I owe this presentation to the long work that I've been doing under funding from the National Institute on Drug Abuse, and as well as from the state of Maryland, who has, I've been in a partnership with the Maryland Department of Public Safety and Correctional Services for pretty much 20 years. So we've been able to do some very interesting laboratory work that we continue to do. Okay, so first of all, when we talk about this beast of the correctional population, most people do not fully talk about the fact that we have actually more than 7 million people, which David had on his chart, mainly because most people don't include the alternative programs that have popped over the last 20 years as organizations have tried to struggle with how to deal with this large population and the number of people under pretrial services. And so the population is actually much larger than that, and I wanted to point this out because what I'm going to speak about is the findings from a national survey that that I'm going to report on that basically looks at practices within the correctional system across jails, prisons, community corrections agencies, and pretrial agencies, both for the juvenile justice system as well as the adult system. And so we're reflecting the full body of what actually is done within the current system. So this survey was done in 2004 to 2005. We surveyed 4 levels of organizations: state correctional administrators, probation, parole, prison administrators at the local units, staff, and treatment providers that work within these agencies to get a good sense of what is actually the practices that occur out there. Now, in my small 10 minutes, I can't really go through all the findings. We have actually 2 special editions of journals that, if anyone's interested, I can refer you to them, that actually report on this. But the things I want to first talk about is the disconnect. So the first disconnect that actually occurs is what is the need out there? Well, when you actually look at the 8 million or so offenders that are under the correctional population, what we actually find just on substance abuse disorders per se is that about 30% of the population does not really have a presenting problem that needs substance abuse treatment services. About 19% of the population has a very minor recreational lifestyle use pattern. About 20% of the population has more of an abuse pattern, which means that they tend to use on a somewhat frequent basis, but about 30% of the population actually have an addiction disorder that needs some type of treatment. And so this is what our need is, and unfortunately, this here refers to the lowest category of kind of services that are out there that actually should not just be substance abuse services, but should actually refer to some other broader array of services that offenders need to address the criminogenic factors that Dr. Wilson alluded to. So the question is, and this is what we learned in our survey, what's the array of services out there? Here's the picture. We've had a lot of discussions. Most of my career, people have been talking about expanding services for offender populations. We continue to see retraction of services, and the services mix is very inappropriate for the population that exists. And therefore, when people ask, well, we can't change this population, part of the answer is not just people are not implementing the tenets that Dr. Wilson alluded to or that are in the criminal justice literature. Part of the answer has to do with 2 things. One is we don't have enough services to meet the needs of the population at large to address those criminogenic factors. The second one is if you look at Malcolm Gladwell's work, we don't have a tipping point within these correctional agencies to really implement programs. And in fact, this is where I'm more interested in sort of this question, which many of you raised with the issue about police organizations, is how do you change these correctional agencies? And what are some of the factors that you need to have in place to really change these agencies? And this is where the partnership that I've had with the Maryland Department of Public Safety and Correctional Services has benefited my work, I believe, and this is why I would suggest to most researchers to engage in partnership with the organizations, because we can learn more about these strategies. So first of all, just to make sure you understand this tipping point issue, on any given day, only about 7% of the offender population can get access to any type of service: education services, substance abuse treatment services, mental health services. That's a very low percentage. And most of these programs are very short time frames, when in fact, if you look at the histories of these offender populations, they need to be engaged in programs and services that are at least 6 months. And I would say we really don't have good research about the duration that we actually need for care to really help people establish themselves more succinctly. The other part is that most of our funding for services actually comes under the rubric of being a substance abuse treatment program, but in fact what we know about offender populations is that they have multidimensional issues, and therefore the programs need to be multidimensional to deal with not only substance abuse disorders, but some other, some work issues related to stability, and things of that nature. And so one of the things that comes out of the criminal justice literature is the importance of multidimensional programming, and Ed Latessa talks about these programs needing to deal with at least 3 criminogenic factors. The thing I wanted to focus a little bit of attention on that comes out of our studies is what are the components of programs, because we were able to use these survey data to actually ask the question, what factors or characteristics of organizations are more likely to adopt evidence-based practices? Because in our survey, we found that the average correctional program actually only adopted about 1/3 of the recommended evidence-based practices. But we had some that adopted 12 out of the 15 items on our scale. So the question, and we were able to do a number of different types of analysis, and there are 3 characteristics that come out of this work. One is that the organizations themselves need to be open to learning about new techniques and embrace what's called an organizational learning environment. This is much akin to what you've heard from Dr. Willis and others about police organizations and change within those organizations. But what this suggests is that we really need to begin to think about how to open up correctional agencies. To that kin, we found 2 other characteristics that were very important in terms of advancing change practices. Another was the ability to create seamless systems of care or work on interagency practices so that treatment agencies and correctional agencies at a very operational level could actually embrace some of these different ways of doing businesses. And we developed a scale that you can actually measure this interagency collaboration. The scale actually predicts fairly well adoption patterns, and with more time I'd be able to go through some of those components. And the last component that seems very important is a clarity of mission regarding the importance of treatment within those organizations. Correction agencies, particularly over the last 30 years, have worn the hat of being enforcers and punishment. Treatment, i.e. this low prevalence of providing services, is actually a foreign body to these organizations. And, and the better organizations have correctional administrators who have backgrounds in health services, that have had, ability to work with different types of treatment programs, but that is not the norm. And so what we find is the need to have a clarity regarding treatment. To skip to the next section, because treatment is one part of the picture, and one area of research that's really understudied is probation. Now, Dr. Willis talked about Dr. Wilson talked about the research findings that basically address the issue about intensive supervision. And, my read on the literature is very clear, that, intensive supervision does not really change behavior. A lot of it has to do with the mission, which has been an enforcement mission. Another part has been because we've been struggling with trying to really define what intensive supervision is. Well, one of the things in my partnership with the Maryland Division of Parole and Probation, and Ernest Ely's here, so Ernest and I, for almost the last 15 years, have been working on different ways of thinking about probation and parole supervision. And we were able to take the 3 tenets that Dr. Wilson addressed and actually put those in place within his organizations in 4 offices. And then we had 4 other offices that we were able to use as a comparison site to look at the implementation of what we call evidence-based probation services, or in his organization, they call it proactive community supervision. And this includes using a valid risk and needs assessment tool to identify those criminogenic traits, developing supervision plans that are responsive to these criminogenic needs, and then highlighting for moderate and high-risk offenders that appropriate attention be given to providing those services. The third part was addressing the issue of what Dr. Willis talked about, which is procedural justice. In the context of probation supervision, what the work now is suggesting is that you need a relationship, some type of working alliance between the probation officer or the parole officer and the offender in order to have the trust within that organization for a person to actually change. And to be honest, that whole concept was alien to many correctional agencies, that you would work on a relationship. But in fact, what we're finding in the literature is that, and actually that tenet itself, Jennifer Scheme out of the University of California at Irvine has been doing some work with mental health patients or offenders, and she continues to find that this working alliance is a big factor in the person, the offender, having ownership to their own supervision plan. Well, we were able to pilot this model and do a study funded from the Maryland Division of Parole and Probation, in which we actually did find reductions in rearrest rates after 1 year, and we also found reductions in technical violation rates. So here was a scenario where you could actually increase the contact between the probation officer and the offender and not end up with more technical violation rates, which was fairly good findings. So, okay. But one of the things I want to point out is that we really don't know how to supervise people. And most correctional probation and parole agencies in this country, and I'd add pretrial organizations. If Susie Schaefer was here, she'd raise her hand too, but she just had to leave. But I'd add pretrial organizations too, that we really need more research in this area. And this is an area in which there has been very little funding either from the National Institute of Justice or the National Institute on Drug Abuse, which is really to kind of find strategies to work with this offender population. So I often get asked the question, so how do you take these surveys that we've done and the results from these surveys and translate them into some practical findings, in terms of things that could help organizations move ahead, particularly in this environment? So here's my list. First of all, I think we need to recognize the shortcoming of treatment services as we discuss the what works principles and as we discuss what's feasible within correctional agencies. The second is that even though standardized risk assessment tools, which have been around for a long time, I even did my dissertation on that in the early 1980s, if Todd remembers, and needs assessment tools, even though they exist, very few organizations use them. In fact, in our survey, what we found was less than 30% of probation agencies actually use a risk assessment tool. So it's very hard to implement in evidence-based practices if the organizations themselves are not actually using these tools. They oftentimes have to do the tools, but they don't actually use them in decision-making. Another piece that I think is very important for organizations to think about is that we have a large cadre of programming called drug and alcohol education. In fact, that's the majority of substance abuse treatment that's provided in our country. We need to convert those programs that are already out there to more cognitive behavior programs, and we need to work with the staff that work within those programs to really understand how to do CBT and some of the more evidence-based programming. Another part that I would really emphasize is, because this comes from our survey on implementation, is the importance of integration of services across delivery systems. And that is an important factor that we continue to see in the analysis that we're doing about implementation, which has to do with the ability for organizations to work at a very operational level. So looking at how organizations can really work on these integration issues is another area that I believe that we should continue to pursue. And then the other kind of factors in conclusion are that, we really have to ask the question, would we expect someone to recover from a significant disorder? Like, I have asthma, right? I realize that, I will not recover totally from asthma. The whole notion is that I really need to, manage my asthma. Well, that is the same thing with a lot of the presenting conditions that many offenders have. And so some of the techniques we really need to think about is sort of borrowing from medical management strategies that exist. There are a whole host of medically assisted treatments out there, particularly helpful for people with substance use disorders. They're not very widely used within the criminal justice system. I want to end my talk by just talking about the organizational culture within correctional agencies. Again, we have a 30-year history that suggests and have pushed correctional agencies to feel that they need to be punishers. And to a large extent, that mindset will not materialize into actually changes for many different reasons. Even if you don't have a strong belief in therapeutic alliance or therapy for people, the reality is very few people are going to change in a system in which people are constantly overlooking their shoulder. And so we really have to find a balance between having more of what I call a behavioral management strategy about helping people to learn to manage their own behaviors. So I thank you very much, and I really want to thank Dr. Weisberg and Dr. Lum for hosting this session.